to the problem with ankle instability often is that the ligament has been injured and is not healed the way that we want it to. So reconstructing that ligament involves basically tightening that ligament so that it functions properly again. Ankle instability is a fairly common problem that I see on a day-to-day basis. Patients often come to me with problems of having sprained their ankle in the past or having multiple recurrent sprains that are ongoing. They often describe having a weak ankle or an ankle that they just can't trust when they're trying to push off of it, run, or do a lot of other athletic activities. This can manifest in not only having this feeling of weakness or instability, but also pain on the outside part of the ankle. Most commonly, ankle instability occurs after a previous ankle sprain. And a sprain is when the ligament, the main ligament on the outside part of your ankle that connects the fibula and the talus bone, called the anterior talofibular ligament, or the ATFL, has a small tear to it. So there are varying degrees of injury. And ultimately what can happen is that that ligament does not heal the way that we need it to heal and is no longer functioning properly. And that can lead to the outside part of your ankle feeling painful, weak, and you constantly turning or twisting your ankle again. I think it's important for a patient to try to see a surgeon early on, even if they're not going to have surgery. I think it's important because most of the time we can have a sprain and we'll recover. The vast majority of us will have a nice recovery and won't have any issues. But unfortunately, there are a good amount of people that develop ankle instability and other issues if an ankle sprain is not treated properly from the get-go. I think the first and most important part of the visit is me listening to you and getting your story to hear just how bad things are. For example, does the ankle instability occur only when you're doing really high-level activities, or does it happen when you're just walking on flat, even surfaces? Those can give me a lot of good information and clues as to what's going on. The next portion after I get a good history from you is doing a thorough examination of not just your foot and ankle, but your entire lower extremity to make sure I'm not missing anything else. Part of the physical examination includes something called an anterior drawer test. That involves me putting one hand on your shin, another hand on your heel, and drawing your foot and ankle forward. And I can compare to your other side to see if there's something called laxity or looseness of the ankle. And that can clue me into as how much ankle instability you're having. In terms of imaging, I generally start with getting x-rays of your ankle and or foot. While it's more rare, there can be other injuries that occur at the same time as you having ankle instability. For example, the more times you turn and twist your ankle, the higher the chances there are that the two bones of your ankle joint collide with each other, and there can be other injuries like small chips of bone or cartilage inside the ankle joint. And there can be clues of that on x-rays. If I'm uncertain, I'll also get an MRI, as an MRI gives me a really good look at all the soft tissue, including the ligaments and the health of the joint itself. In general, for ankle instability, there's two big categories of treatment, one involving surgery and one not involving surgery. As a general rule of thumb, I try all things short of a surgery before we go down that route. In terms of non-surgical treatment, this can include bracing, physical therapy, activity modifications, injections, and some other options as well. In terms of surgery, I generally reserve this for a situation in which we've tried everything short of a surgery, and if you're still having issues with ankle instability and you're not able to get back to doing the things you need to or want to do, that's when I bring up the topic of surgery. In terms of surgery specifically for ankle instability, it generally involves two parts. The first part is called ankle arthroscopy, which is basically me putting a very small camera that's a couple millimeters big inside the ankle joint to start with, to look inside. That's because we've found that with recurrent twisting and turning of the ankle, there's often other injuries in the ankle joint itself. And through an arthroscopy procedure, I can not only identify if there's other issues going on with the ankle, but I can also treat it at the same time. And then the second part of surgery is what we call the modified Brostrom procedure, basically a fancy word of way of describing an ankle ligament reconstruction. So the root of the problem with ankle instability often is that the ligament has been injured and is not healed the way that we want it to. So reconstructing that ligament involves basically tightening that ligament so that it functions properly again. The way that I do that is I use something called a suture anchor. You can think of almost like drywall technology where the anchor goes into the bone and it has sutures attached to it. And I use those sutures to repair that ligament back down. One of the things that I'm really passionate about and excited about is minimally invasive surgery. I like to perform this particular procedure in a minimally invasive fashion. So the general concept being performing safe, effective surgery through incisions that are as small as possible. So the incisions that I make for the arthroscopy procedure or portion of the procedure are very small. They're small enough to require a single stitch, one on the inside part of your ankle, one on the outside part of the ankle. And I'm able to do this procedure through those very small incisions and potentially needing to make one extra incision. And I think this is a game changer because in comparison to the more traditional route, it's a much smaller incision and I'm much more confident about allowing you to start the rehab process sooner. Some of the main advantages of minimally invasive surgery are that the incision's much smaller. So that makes me much less concerned about wound healing complications or infection. Patients often have a lot less pain because the surgery is less invasive as well. So that also is advantageous in terms of minimizing the amount of pain medications you might need after surgery. And also, I'm able to often get you started on the rehabilitation process a lot faster. In terms of rehabilitation and what to expect after a procedure like this, for the first 2 weeks, I generally have patients stay off of the foot in a splint that I apply in the operating room. And at your 2-week post-surgery visit, I take the splint down, the sutures come out, and then you can start washing it, getting it wet for hygiene purposes. And at that time point, if the swelling has come down enough, I get you into a lace-up ankle brace and get you started with physical therapy. For the first 6 weeks, there are certain motions that I ask you not to do, but I would guide you through that and talk with your physical therapist about that as well. In general, around the 6 to 8 week mark, I am having patients ease into full activity, and I have patients wear the brace for all activity, weight-bearing type activity for the first 3 months after surgery, and for all higher risk activities like running, jumping, cutting for the first 6 months after surgery.